Now, what I'm saying is that a doctor has to be a guidance system. He is not an oracle that knows answers. And once he accepts the concept of being a guidance system, then he knows that the data system is the basis from which all his work must take place. And then the record suddenly becomes an unbelievably important document in education, in care, and in research. But as long as we were a profession that thought we could rest on the memory, and it was what you know makes a difference instead of what you do, and as long as we thought of doctors as oracles that know answers instead of guidance systems in uncertain situations, we were willing to let the record in American medicine fall to this level. And now when the computer people move in, and the Medicare people move in, and the non-medical people move in, they can hardly believe what they see. And there is a crisis of major proportions. First hospital I went where we decided to stop source-oriented problem-orienting records, the first thing I did was we canceled all the conferences and all the rounding that wasn't directed to specific problems, and from 6 in the morning till midnight, 7 days a week, we got these things so the database was defined, the problem lists were up to date, the plans were in order, and there were progress notes at the right frequency. It's just like a fifth-year graduate student in biochemistry. When it gets down to the time and he's got to get out, he stops going to hear the Nobel Prize winners. He stops all these conferences. He stops running around. He isn't going out with dinner with his wife. He isn't chatting in the hallway. He's doing one thing. He's in that laboratory and he's working on that thesis. And this is a doctor's thesis. He may get A in all his courses, but if his thesis is no good, it's not creative, the work was no good, and it's unreliable, all those A's in advanced calculus and biochemistry mean nothing. And the same way with us. If this is not interpretable or auditable and the quality is not good, then all the rounds and all the specialization, all the NIH and all the hierarchy mean nothing. Mean nothing. Now you might say, well, but don't you think we should have research? Well, yes, I think we should have research. But this is research. Every patient's different. We don't have to run away from the bedside to be profound and to be unbelievable scientists. I worked a long time in pyrimidine chemistry, nucleic acid chemistry, and I can tell you from my own experience, and I was at Penn when the Meyerhoffs and all those people were there, and I've seen the best. And there is nothing that taxes you intellectually or taxes your sense of science and philosophy the way this situation does. Basic scientists who've been allowed them to focus on 1 or 2 problems and keep their data in a separate notebook and come in from 8 to 5 and shut off the incubator when they wanted to go away. They have no concept of what it is to have 5 problems per patient, 30 patients on the ward, 150 problems running simultaneously. They never taught a data system for that. But because it's so difficult, and because it's just in its infancy of what we could do, doesn't mean it's unscientific or that it's unsophisticated.